Right, I would now like to invite Annie, Dr. Annie Madden, to come up. And also, Kwame, you should be sitting on this panel. So maybe, I don't know if there's a chair for you.
No, we don't. You have to bring a chair.
Isn't there? Is there a chair? No, there's a chair on the end, I think.
There's a chair. Yeah.
There's a chair there.
Yeah, Annie.
Okay. Good afternoon, everyone. It's fabulous to be here in Cape Town. My name is Annie Madden. I'm from the International Network of People Who Use Drugs, and I'm a lead investigator on the low dead space needles and syringes study, and particularly leading the community-led values and preferences research for the CUTS Hep C consortium. So I've just been asked today to do a kind of quick overview on why values and preferences research matters and how to make it count, especially around translating community-led research into harm reduction policy and practice. So I guess, you know, we've known for decades that needle and syringe programs save lives. They prevent HIV and Hep C transmissions, they connect people to information and services, and they strengthen communities. And yet, despite that evidence, too many programs still fall short. Supplies run out, poor quality and the wrong injecting equipment is repeatedly procured, people feel judged, unsafe, or simply unwelcome. So the question isn't really what works. We know that. The question is, whose voices guide what we do? That's where values and preferences research comes in. It is research that asks what truly matters to the people at the heart of harm reduction, that is, people who inject drugs. It looks beyond outcomes and statistics to understand living experience, what makes a service trustworthy, accessible, and worth using. When this research is also community-led, it becomes truly transformative because it shifts power. It tells policymakers not only what is effective, but what is ethical and acceptable to the community, that is, to the people they are meant to serve. So why does community-led values and preferences research matter? Well, let's be honest, harm reduction has always been values-driven. It's rooted in dignity, autonomy and rights, but all too often harm reduction policies end up reflecting and being driven by what is politically palatable rather than by community realities. When people who inject drugs lead values and preferences research, they surface truths we might otherwise miss. That trust and autonomy can matter more than convenience, that being treated with respect and dignity is as vital as having access to the right needles and syringes, that a program's tone, whether it is welcoming or punitive, determines whether people will ever come back. And this matters directly for procurement and needle and syringe programs. Community-led studies have shown that NSP stockouts or procurement of poor quality and/or the wrong injecting equipment forces people to reuse syringes and/or share supplies. These are not technical errors. They are failures to ask, and more importantly, they are failures to listen. When procurement reflects people's values, ensuring the right mix of needles and syringes, sterile water, filters, tourniquets, etc., something happens. Harm reduction becomes safer, more effective, and more humane. So let's talk about translating community-led values and preferences evidence into policy and procurement. While we're starting to see more discussion about the importance of community-led values and preferences research, there is much less discussion about how we make community-led research count in policy and practice. The first thing we need to do is reframe the work. And it is work, a point I will return to soon. So this isn't consultation with service users, it's co-production of evidence. That means embedding networks of people who use drugs in every step of the process. Research design, policy design, service planning and delivery, procurement planning, and review and evaluation. It means translating community insights into policy language that decision makers can understand. For example, if the community-led research says that people value safety and trust, the policy takeaway should be invest in low-threshold, stigma-free service environments. But translation requires structure. So this means building mechanisms of translation. So to start with, this means using participatory research methods such as peer-led services, peer-facilitated focus groups, deliberative workshops, storytelling sessions, visual mapping, where participants can, or service users can map their typical visit or their service journey that can surface values. This is not rocket science. It doesn't need to involve expensive formal research. I know that is the work that we've been talking about here. Research that's been well funded and is very formal research and over a long period of time. But values and preferences doesn't need to be that to be effective. If you don't have many resources, you can have suggestion boxes, you can identify some key peers to do some micro conversations with service users while they're on outreach, or when people are visiting services, you can do short surveys, you can do focus groups led by peers, and then you can share a one-pager with people that says, here's what we heard you say, this is what we're going to try and do next. As simple as that. And then you can ask the community to vote on that and provide feedback. And then you adjust that feedback based on what they tell you, and then you pilot it, and then you adjust again. And then down the line, you might set up a peer advisory group. And then you might have ongoing conversations around how you track improvements. And then you might eventually build yourself all the way up to partnering with a drug user organisation to do community-led research of this formal kind that we've been talking about. Or if you've got funding, you might start there. But there are many, many ways to do this, and it, as I say, is not rocket science. It is about being bothered to ask people to put the community at the centre of what you're doing, and most importantly, when people talk to you, listen and act on it. I think the other thing that it means is that you need to also look about combining any community-led insights that you do gather with standard program utilisation data and waste tracking, because this will allow you to track outcomes in relation to harm reduction, cost effectiveness and scalability, which is very important if you want to translate these community-led insights and program data into real change at a policy and practice level. So to finish, I just want to look at how, given that we now know how to do it, how do we make community-led values and preferences research count? To make it work systemically, we need to embed community voice, not just invite it. That means funding drug user-led organisations as research producers, not just as stakeholders. It means paying community researchers and peer workers to recognise and value their knowledge, their skills and their expertise. And it means providing stipends to acknowledge participant expertise, time spent and out-of-pocket costs. It means requiring community values and preferences statements in all harm reduction tenders and procurement guidelines. It means training policymakers and program managers to regard community-led and co-produced qualitative evidence with the same legitimacy as quantitative and epidemiological data, the so-called expert data. It means co-developing monitoring frameworks that measure not only coverage, but alignment with community priorities. And it means creating feedback loops, keeping communication open so procurement evolves with community needs, because community values and preferences shift, and good policy listens continuously, not just once and not just when and if it suits us. When we institutionalise these kinds of processes, values and preferences research stops being an afterthought. It becomes the backbone of responsive harm reduction programming. So to bring it all together, evidence tells us what works, but values and preferences tells us what matters. If harm reduction is truly about dignity, choice and safety, then people who inject drugs must not only be heard, but lead the evidence that shapes programs and procurement. Community-led values and preferences research doesn't just make policy better, It makes it belong to the people it serves. Because in the end, making harm reduction count means making values and preferences of people who inject drugs count. Thanks.